Good morning. Welcome to the Department of Medicine Ground Rounds. A few announcements. We have a special guest today that promises to be terrific. And he's scared to death that I just said that because now the expectations are really high. But a couple of announcements. First of all, in 2 weeks we'll have the Southern Regional Meeting in New Orleans that occurs every year. It joins a number of societies such as SGIM and Southern Society for Clinical Investigation. And that latter one is an honor society that accepts nominations for individuals who are quite accomplished. And this department has been one of the fastest growing in membership in that society based on the talented group of people that are sitting before me. And so this year is no difference. Dr. Glenn Hurst from cardiology, Amy Dwar from nephrology, Mike Flaherty from cardiology, and Neil Roberts in rheumatology, who's not even here yet, but we nominated him, have all been accepted into the Southern Society for Clinical Investigation. So if you see them, please congratulate them. The second point is that yesterday in the radio I heard that Monopoly had gotten rid of the iron. Oh, okay, they have a cat. I don't know, I never cared much for Monopoly. But did you know that Monopoly was first marketed by Charles Darrow on this day, back on 1935? Okay, but this is all about medicine, no? So Shigeshi Shiga was born on this day in 1871, February 7th. And Shiga was a Japanese bacteriologist who discovered in 1897 Shigella, okay, the bacilla for dysentery. Ruth Sager was born on this day in 1918, and she was an American geneticist who, before her, we didn't know that there was genetic material outside the nucleus. After her, we knew that there was genetic material that could influence inheritance, and that it was located outside the nucleus. So that was an important discovery. But today is about addiction. And addiction sometimes happens because of drugs that we take for pain. And pain is transmitted through neurotransmitters that affect nerves. And that's important because on this day, back in 1905, was the birth of Ulf von Euler. Have you heard about Ulf von Euler? You need to, because he was a Swedish physiologist who shared in 1970 the Nobel Prize for Physiology and Medicine for his work on neurotransmitters. And back in 1946, he actually discovered noradrenaline. And before that, in 35, just because you thought that was not a big achievement, he actually described and named prostaglandin. So today was the birthday of Ulf von Euler and the eradication of the iron on the board of Monopoly. So with that, I leave you Dr. Barb Casper, who's going to introduce our distinguished guest.
Good morning. It is my pleasure to introduce our Grand Round speaker this morning. Dr. Chris Stewart graduated from Georgetown College prior to completing medical school, his psychiatry residency, as well as a fellowship in addiction medicine at the University of Louisville, so he's certainly one of our own faculty. We're very fortunate that he chose to remain on faculty at U of L, where he now holds the rank of assistant professor. Dr. Stewart has been a leader in the area of addiction medicine in our community. He is currently the director of the Addiction Fellowship Training Program at U of L, as well as the medical director of the Jefferson Alcohol, Drug, and Abuse Center, or as we probably know it, JDAC. He is a consultant for psychiatric services at the Healing Place, the chairman of the Physicians Health Committee at U of L Hospital, and a member of the Kentucky Physicians Health Foundation. He has a very active practice in psychiatry within the university, and he has numerous publications in the field of addiction medicine to his credit. And in his spare time, he has been invited to, as a speaker both locally and nationally, along with having 2 small children. We are delighted that he will be speaking to us today about addiction medicine, and I think it is particularly timely in Kentucky with the health impact of addiction in our state, as well as the impact of the new regulations on controlled substance prescriptions on healthcare professionals. Dr. Stewart's lecture is titled Confessions of an Addiction Psychiatrist, and I want to thank him again for being willing to present Grand Rounds for internal medicine. Dr. Stewart.
Thank you, Dr. Casper. It's always an honor to be asked to talk where you've grown up, and I hope I've grown up here. I've been here a long time, and I've thought about leaving a few times, but it seems like every time they suck me back in, and I can't get away. But it's definitely been a great journey to be here at U of L, and where I come from, this was the big city for a long, long time. It's not so big anymore. But anyway, thanks for having me. I do chair the Physicians Health Committee for University Hospital, and I would like to thank two of the members on that committee that are listed, Dr. Cook and Dr. Urbach. I really appreciate their support this past year especially. And if you don't know about that committee, please ask me about it or ask one of them. I'd be happy to talk to you. We're really here to serve the staff of the university, the hospital, which involves residents and faculty and attendings. And yes, we do sometimes have to intervene every 3 or 4 years on someone, but it's a very important committee, and so thank them for serving. So Dr. Urbach, this is probably a story about him. So he was, since Dr. Roman gave these dates in history, this is really actually perfect for my presentation today. I was a medical student and Dr. Urbach was the lecturer. I'm pretty sure. It's been a while, and I was pretty sure it was him, but I wanted to make sure he was here then. He said he was. So he asked if a patient came to you, and well, the question was, and had been sick and had missed work and brought in and wanted you to write an excuse after the fact to excuse them from work. Would you do it? And raise your hand if you would do that. And nobody would raise their hand. So, and I raised my hand. I remember that. And he said, and I thought he's gonna. So yeah, I probably would. And I thought, hey, I'm going to get in trouble. And he said, oh, I probably would too. And everybody, yeah, it's great. Salient points of memories, right? Memories are important. You remember these moments in time. That's going to be really relevant today since we talked about on this day already. And on this day, I have some things to add to that. This is a little bit about my experience. I have pretty much dedicated most of my career to the treatment of addiction. I like addicts, I like alcoholics, I enjoy working with them, and I do see a psychiatrist, so. All right. Addiction. There's a lot of different definitions. It's not an easy thing to define. More and more, we are working towards a more working, evidence-based definition. This is one that I like. Partly informed by ASAM, the American Society of Addiction Medicine, which I would encourage all of you all to consider membership in. I guess if I had a pitch, that would be it. The continued use of a substance despite knowledge that it is causing harm. So that's pretty key. Knowledge can be sometimes, well, it's misspelled here, but knowledge can be kind of soft. Sometimes our patients don't seem too knowledgeable about what they're doing, but they usually know that it's causing harm. The habitual psychological and physiological dependence on a substance that is at least in part beyond voluntary control. And I don't want to give the impression that if you're an addict, you are not responsible for the choices that you make, or that you don't have choices, or that the things that you do you're not responsible for. But clearly, there are elements of addiction that go beyond choice and morality and character. You all may already be aware of that, but we still really fight that. Even within myself, when I'm dealing with patients that I get really frustrated with or have strong reactions to, I often have to remind myself who and what I'm dealing with all the time. And it's easy to sometimes think that, they don't have to be this way. But the development of involuntary compulsive behaviors related to, so that's not just the drug use, but the lying, the manipulation, the rituals that go around addiction that drive us all crazy when we deal with some of these patients. That's something that you're definitely going to have when you have someone who's addicted. So why treat addiction? You never know what may happen, right? Keith Richards is sober, actually, and so if you thought maybe he was still using or drinking, according to him, he's still sober. And if he can get sober and he can get better after, really, if you've read any of his autobiographies, anybody read the Keith Richards autobiography? No? Nobody's a Stones fan in here, really? I mean, I was born way after the Stones, so I mean, I love the Stones. He definitely was a heroin addict and anything else he could use, and probably alcohol too, and has had a number of, he's been, carried the mantle for being the drug addict who won't die. But really, what people don't know is about 20 years of almost continuous recovery, according to him, which is often surprising to people. But I guess the message here is that people do get sober, people do get clean, people do get better with treatment. And so addiction is not this hopelessly untreatable condition that we've sometimes either gotten frustrated with and decided that that's the case, or been taught over the years. So in the theme of saliency, I want to give a case, and I want to tell a story. On this day, since we're talking about Thursdays, it was a Thursday. It was in probably February. I got a case for a 19-year-old. I was covering the consult service for Dr. Frierson, one of my mentors, who I'll always be eternally grateful for. And this was a case about a closed head injury who had been running from the cops, the story was, and had swallowed a number of balloons of drugs in the chase, and was in restraints, agitated, recovering from the head injury, cursing, was asking to eat food, and they kept telling him they were going to get him a swallow study so he could eat. And they wanted me to help out with basically what was going on, which was confusion, withdrawal. He had a urinary tract infection. They were treating that. The speech pathologist came in to do the swallowing study. This guy had tattoos all over his body. He had been to prison for had been just recently released for drug trafficking. And he had a tattoo on a very conspicuous place, among a lot of places, but on one particular place, and he had a catheter, and so the tattoo was very visible. And I can never forget this tattoo. It's burned in my brain, right? And when you talk about memories and things that you remember, this is always tied to this day. I was able to help get the swallowing study. He kept asking for the speech pathologist. They said, well, she's going to come, and you can't eat until she comes. And he was improving, and he was yelling, her name was Melissa, and he kept saying, I want Melissa, I want Melissa. And she finally showed up, and then he was cursing her and calling her names, and I helped him get the swallowing study, or at least cooperate with it while I was there. And so that's my wife, Melissa. That's how we met, over this patient with a tattoo that we both always talk about to this day. And that was 7 years ago, maybe 8 years ago. My daughter's 5, and my son. So we owe, my children owe their existence probably to the guy with the tattoo on his you-know-what, who was, definitely an addict. And so why treat addiction? Maybe you'll meet the person. Maybe that's not a good thing. Maybe you don't want to have that happen. But I'm sure people have stories. But it was on Thursday, and it was maybe this day. Might as well, since we're doing that already. Salience, again. Things you remember, either good or bad. It's important. So anyway, what causes addiction? Well, we know a lot about what causes addiction. We actually have a lot of evidence and research that tell us now what probably leads someone to getting addicted. It's not a mystery, as it might seem to be, or has been in the past. I remember when I was a student and even a resident, we really didn't have as clear an idea as we do now about what can things lead to addiction. And here are some things. Not all these things are required, but these are some of the top things. You've got to have exposure to the drug that's reinforcing. And the reinforcing mechanisms of the brain are well studied and have now been elucidated quite a great amount. But you've got to have an exposure. So obviously you can't get addicted to something that you've never taken or ingested. It helps to have a genetic predisposition. And this is really important. This is more and more important all the time. We think that probably addiction is as hereditary as diabetes, maybe even more so. Past history of abuse or stress in childhood is a big risk factor for the development of addiction later on, and that's because of what happens in part to the stress regulation system, our cortisol system, our adrenal corticoid neurohormone system for managing stress. It becomes essentially dysregulated early on, and many people who get addicted, they're not really able to relax, essentially, without being able to describe it more complicated than that. And so when they come across drugs around adolescence, it's a major relief for them at the time. And they're very at risk for becoming addicted. In fact, if not all of my patients at JDAC, at least 80 to 90% of them all have a history of abuse or stress, significant abuse in childhood. But this is not the same. You can grow up in a good family and not be, you can get addicted. Just because you have addiction doesn't mean you had this, and that's the other thing. That sometimes there's a lot of shame in families or in patients when there's addiction, and it doesn't always mean this. Drug availability, I've heard it said that smoking is more addictive than heroin, smoking tobacco, and I just can't agree with that at all. It's very addictive, and I used to smoke, and I would love a cigarette probably right around now. It would be good right now to have a cigarette. But the reason that smoking is one of the reasons I think it's so hard to quit is it's available and had been for a while an accepted form of use. And heroin is not as accepted, and until recently hadn't been as available. And it was still, when people who get addicted to heroin, we'll talk about it, it's very, very hard to quit that. And people do probably quit smoking more successfully than they give up heroin. Living in a stressful environment, if a patient is at JDAC and they're going to go back to the same place they came from where there was a lot of violence, drug use, and being addicted is very stressful. It isn't fun. It isn't something that you're having a good time and you just don't want the party to end. The party stopped a long time ago for people who are addicted, and part of treating it is getting the stress reduced. But if you continue to be in a stressful environment, it's very hard to stop. And that can also lead to what we see. So if you're going to prescribe pain medication for someone, this is a good list right here when you go and pull my slides up. These are significant risk factors that are listed in the SAMHSA tip on treating chronic pain. And if a person has a history of smoking or a history of substance abuse, has a history of a mood disorder or sexual abuse, they are going to be at greater risk of developing maybe my thing isn't on because now I'm hearing myself. It's working? Okay. They're going to have a greater risk of getting addicted to those pain meds that you prescribed. So maybe you want to use greater supervision in this individual, shorter time period if you're going to prescribe pain medications, and you really want to think about not going to narcotics if you're going to be treating chronic pain. And I did a presentation recently to the KPMA on treating chronic pain in people with addiction. I don't plan on doing that a whole lot today. We can certainly leave time for questions and go a lot of different directions if you want. But anyway, Dr. Roman talked about all these things to remember, and when it comes to addicts, they remember the first time they used. And this is very important to understand about drugs that are addicting is they produce definitely an experience that we call salience. And salience is very important to survival. And salience is basically the description of three things, typically: pleasure, novelty, and misery. So not always good stuff, but stuff that gets our attention. And that's important for survival. We need to be able to stop for a minute and focus on the fire alarm that's going on if we all needed to run out of here quickly, or rather than pay attention to all the different, maybe minor things that are going on. Stuff that gets our attention. That's important for survival for obvious reasons. It also, with an addiction, salience is the gateway, and we have dopamine tracks in our brain that, when we experience pleasure, release the chemical dopamine, and we experience the sense of euphoria or the sense of ease and comfort, or actually a sense of pleasure, which is can be exciting too. And drugs of abuse hijack this circuitry. So you have a thing called, a concept I'd like to try to impart called dopamine receptor density. All of our brains have a certain density of dopamine receptors. And as we age, that density declines. And our ability to experience salience gets a little less with time. This is what happens much more quickly to the person who gets addicted to a particular drug. And drugs that we get addicted to almost all use the final common pathway that involves dopamine. And essentially, the hijacked circuitry, all it wants to do is obtain the drug. And before, when you would get pleasure from watching a movie or hugging your child or eating something that you liked, now, because of what's happened to your dopamine receptor density in part, and it's gone down from the drug use, that doesn't do it for you anymore. And the only thing that does it for you is the drug. And there also may be a lot of really negative things that go along with that too. But you still want that stuff as well because it's salient. And so we see people who lose control. And there is impairment in the orbitolateral prefrontal cortex as well. That's the I shouldn't section of our brain that's often hyperactive in OCD. In addicts, it becomes underactive over time by the use of the drug. And so, one, you have an increased attention, and I've got to get a saliency through the use of this drug, and the other is the consequences are minimized. And it's really a brain impairment. It's really a brain damage that happens with the use of the drug. So this is also why talking to somebody about their drug use while they're actively addicted isn't so effective when you try to talk to them about how they shouldn't be doing this. That part of their brain is able to hear that. That's not how we always thought about this problem. Even when I was a student, I thought about it much more of something that if I just was passionate enough and convincing enough, I could really help my patients understand they had a problem. If I confronted them enough with their consequences, they would get better. They would at least maybe see that I cared enough, they would try to do something to get sober. Another, when I talk to patients at JDAC, I always talk about delayed discounting because they totally understand this. And I say, your brain has been damaged by your drug use, and so your reasoning abilities to weigh out the consequences about what you should or shouldn't do, that's been affected, and you're not as capable of making a good decision about whether or not to use drugs or continue to use. And it's not your fault. Totally. You've chosen to continue this, and you can accept treatment, but some of this happens before you even realize it. And let me give you an example of what happens. After people get sober from cocaine, there's a phenomenon that has been definitely researched and shown to be evident in people who have stayed sober even for 3 to 6 to even 18 months later, and that is a phenomenon called delayed discounting. And this is basically the delay of gratification that is lacking in people who are either in early recovery or have who are just stopped using. And I'll explain it this way. So if someone offered you today $1,000, and you could run off and have $1,000, or if you'll just wait a week, it'll be $10,000. Okay, all of us, I hope, would wait a week and take the $10,000. Now, they all know what they would do. They all say the same thing at JDAC. They say, "Oh no, I take the $1,000. I wouldn't wait a week and take the $10,000." They know they could buy 10 times as much drugs with the $10,000 as with if they would just wait a week. They can't wait a week. They don't know why they can't, but they know they can't. And they discount the value of the $10,000, and that is not simply a matter of being immature. It is literally a function of their impaired or damaged brain. So they like that story. They like to hear that. They start to talk to each other about you wouldn't wait, I would, or they go back and forth. So I think it's important. That's an important different frame change than what we've been used to doing and dealing with addicts, which is you've got to stop using drugs, you got to go to meetings, you've got to change your way of living. We really have much more evidence now that there are things that we need to be doing to target the brain and help the brain recover. And also, even when people are actively using their things, we need to be thinking about differently than we have in the past. So much of the past at university, and I'm part of this group, the people who treat addiction are people who are in recovery from addiction. And that's been a problem because you get the idea that unless you've got it yourself, you can't treat the problem, right? Or unless you have a loved one who's had the problem, you can't treat the problem. Or if you're not in recovery in Al-Anon or AA. And that's been important in one way. Before we had a group of people who were in recovery, we didn't have probably the disease concept. But we're now entering that stage where in this community too, we need more people who aren't in recovery treating this problem. Do I have to have diabetes to treat diabetes? Really? Because patients will say, have you been addicted? Are you in recovery? And I'll say, I'm not going to answer that question. I don't say, on the grounds that it might incriminate me. I say, do I have to have diabetes to treat diabetes? Really? Are you going to ask that in anybody who tries to help you, that they have to have had the problem? I mean, that idea seems to rest with addiction more so in medicine even. And we need to move, we're ready to move away from that now. And this is one of the first people who really taught me that. How many knew Dr. Blondell? So he's not coming back, right? Everybody says, well, if we could have Dr. Blondell, that would be great. If we could have him to do consults again. He's not coming back. I mean, if you've heard something, please tell me. But I talk to him every time. He's not coming back. He's a national leader in addiction medicine. He's on the board of the ABAM, which I would encourage anybody here to consider ABAM certification. Anyway, he's not coming back. So that's my second point, which you should be engaging in brief intervention with your patients. We're required by JCO to do that to be a level 1 trauma center. I don't think we probably do it. Maybe we are doing it. Back in the day when I've been in the hospital, I don't see this going on a whole lot. Rick was really important on bringing that to the hospital. And also, his legacy was brief intervention works. You can actually have an impact on patients with addiction in the hospital, doing even brief screens, and then giving them medical advice on why their addiction is causing them problems. As a physician, the role of physician is still very, very important. And there had been this assumption that really the best people to help addicts are other addicts, not doctors. And it's true. They can be really helpful, and we constantly encourage my patients to get involved with addicts. But doctors play still a very, very important role. So why should you learn to treat this, particularly in internal medicine? Because the cavalry's not coming, right? If you try to get a patient in with me, I'm too busy. I'm not even taking new patients right now, which I hate that actually, but I'm not. And I can't see any more patients than I'm already seeing. There aren't going to be enough addiction psychiatrists in 10 years, in 20 years, that, as far as I can tell. Maybe that'll change, but there certainly aren't going to be enough psychiatrists. There's probably not going to be enough doctors to treat all the patients. And in case you noticed, we've had an opiate epidemic in Kentucky, and House Bill 1 alerted a lot of people to that. But you're going to have to get better at treating it and recognizing it. And it's not as hard as some of you might think. Some of you may already know this, and so I'm not speaking to you, but it's really not as hard to treat addiction as people have believed. And why should you get training in treating addiction? Well, if you do, your life will be a lot easier. When you're in the hospital and you're on call, it's definitely a lot easier if you know how to detox someone, or if you even know some skills beyond that. And as a physician, in an academic center, you're already qualified to be to sit for boards probably in addiction medicine. So you're going to deal with this problem. It's not going away. It's here to stay. It's going to be more and more important as we form these large, big organizations. Why isn't Rick Blondell coming back? In part, he's not coming back. We're not going to have Rick Blondell doing an addiction service at the hospitals because he can't get reimbursed for that in the current system. It's not going to ever be enough. It's never going to make enough to really pay for itself in that way. Although he did reduce restraints, the use of restraints through proper detox. I'll tell a little story. They used to give alcohol to alcoholics, even still at University Hospital. And it's not very effective, but it was really this idea that, so what? I'm not treating their addiction. I'd rather be their bartender than their psychiatrist. I heard lots of doctors say that when I was a medical student. And he was one of the first people who challenged that notion by starting a service that showed, yeah, you could do it. You could do addiction medicine in the hospital, and it would be effective. It was profoundly important. How many people know Burns? Burns Brady. Burns is great. He's one of my good dear friends. He's been very influential, and he's part of that group I was talking about, the recovering people, who really pushed the disease concept and established it in Louisville, that addiction and alcoholism and drug addiction was a disease. And that's still very dominant. And I'm very much influenced by this. My work with the Healing Place, I love the Healing Place, and working with doctors. It's the best model for doctors, for sure. But what it sometimes does is abdicates responsibility in the hospital because, well, they don't want sober, if they don't want to get help, then there's really not a lot we can do. Burns, if you don't know, elevated the role of the Kentucky Physicians Health Foundation and really solidified that doctors aren't going to just lose their license if they get in trouble. I just wanted to say a little bit about that. I'll try to stay on time. Very strong advocate for the 12-step model. Has anybody been to CAPTASA or gone to the CAPTASA conference? Yeah. So CAPTASA is a conference every year that's in Lexington. And it's good, but it's very much a 12-step based conference about the value in a 12-step approach to addiction. In Recovery Kentucky, before the House Bill 1, was one of the major pieces of legislative initiatives that we had, which was to replicate the Healing Place model throughout the state, and it has done that. But it gave this, in my opinion, false sense of satisfaction. A lot of times the answer to the addiction problem in our hospital, and I would hear, well, just send them to the Healing Place. You're going to send everybody there? Really? I mean, it's really the solution for homelessness that's often related to addiction, but it's not the solution for everybody, and it doesn't provide medical detox. And I don't want to criticize the Healing Place at all, because seriously, they take anybody, and I think they're absolutely wonderful, but they agree themselves, they don't do everything. And we have needs that go well beyond that. And so that's just not the only thing we need to do. So anyway, I did want to cover some of the objectives. So some myths, and this will be hopefully interesting. You have to hit bottom before you can get sober. How many people thought that? Have heard that? Anybody in here? Everybody know? Okay, raise. So we don't really think that anymore. We don't really like that idea. In some ways, it's been counterproductive. You have to let people suffer longer. How many chronic diseases do you know where it's better to let it go on and on and on before you intervene and decide to do something about it? Well, we don't do that with any other chronic diseases. It's much better to intervene early and try to get someone even on the road to recovery than waiting till they're ready. This idea that they're not ready yet has been, and it's really not fair to put that on the 12-step abstinence people either, per se. That's certainly something you got from the 12-step AA community, but the truth is coerced treatment is just as effective often as voluntary treatment. And sometimes patients will say, well, I'm here for the right reasons. And I said, well, I don't care if you're here for the wrong reasons or the right reasons or whatever. It's just important that you're here so that your brain can start to basically be away from the drug, and so your brain can begin to recover. And abstinence alone will help the brain recover. Other myths, you got to get sober first before you can get help with your depression or your bipolar disorder or anxiety. In a way, that's kind of true. You can't really treat somebody for depression when they're actively in withdrawal or detoxing. But we now know that it's much better to treat both problems. If someone has depression and they're continuing to be clinically depressed for whatever the reason, in their early recovery, they're going to be much more likely to relapse. And this kind of goes away with what we had been taught. You just need to wait 90 days. And it's true. If someone will abstain for 3 months, there's a lot less likelihood that they'll have a depressed mood. And so I still come up against that a lot, even within myself. But it's important to recognize certain mood states and treat them, whatever the cause. Taking medications to stay clean, sober. Now, this has been, believe it or not, Vivitrol and naltrexone and some of the drugs that have been approved for the post-acute withdrawal syndrome and alcohol. were very controversial among a lot of people in recovery. That's cheating somehow. And that would be, again, like diabetes, not to beat a dead horse, but look, don't take insulin. That's for wimps. You need to try to adhere to the diet. You know, can't you just not eat the right foods? Probably not exactly a fair comparison, but there's really no harm in taking some of these meds. Do they help that much? We don't have a magic bullet for alcohol yet, but it's not cheating. And the other one I hear all the time is you're enabling the addict or the alcoholic. How many people have been familiar with that? I heard a social worker tell a patient last week, you know, you're enabling your son, your adult son. You need to let him suffer on the street with his opiate addiction. This patient was in the hospital, and I said, actually, we don't tell people that anymore. One, it implies blame. You have somehow made this happen because you have been an enabler. And therefore, if you would just quit enabling, your family member won't be addicted anymore. And believe it or not, that's a definitely implied message, and that's not the message we should be sending. This is a medical problem, and maybe there are things that you can try to do, but people who are suffering from addiction in their families are suffering themselves and often need help. And so what we know is when families stay involved, outcomes are better. Duh. Right? The other one is, if you're addicted to alcohol or addicted to opiates or cocaine, it doesn't matter, the treatment's the same. It's not the same, it's different. Drug addiction syndromes are very different. Yes, if you're a cocaine addict, you probably shouldn't drink. And I don't have people come in yet and say, I just need help with the cocaine, I still want to smoke pot. Is that all right? And we say, sure. We haven't gotten to that point in addiction treatment yet. I don't know if that would be, I'm not ready for that. I don't know if that'd be a good idea, but we're not at that point yet where we're going to tell people that they can still use one drug and not another. We'll talk a little bit. I knew I had too many slides, but it's been obvious that the trends have changed. And I know you all are probably mostly aware of this if you're seeing patients at University Hospital, but at JDAC it's true that we used to treat alcoholism at JDAC, and we were really good, and we still are really, really good at detoxing alcoholics. I think we do, for the money, as good a job as anybody can in a very efficient way of treating alcoholism and treating it, avoiding hospitalizations. We save a lot of money from diversion to the ER, but that population as part of our treatment group has gone down significantly. And who do we treat now? We treat the young, immature, addicted to pain medications and now heroin, young people. And that's 80 to 90% of our treatment program. And it's just literally changed. It seemed like it changed overnight. And then we watch them walk out and we hear about them dying and ODing. And the same program for alcoholism at JDAC is not now the same program for opiate addiction. It doesn't work. You can't treat opiate addicts like alcoholics and expect them to recover. They don't. They relapse much higher. They don't do nearly as well. Cocaine, I love crack addicts. Give me a crack addict any day over an opiate addict. They're usually more motivated and more easily treated. That's probably because of the binge nature. They'll get clean, just by their nature of their addiction. And alcoholics are usually really grateful. But the opiate addicts, not to be stereotypical, but they're young. They're usually not happy to be in treatment, and they don't really appreciate anything that you have to offer them at JDAC. And who caused this problem? Well, we did. Doctors caused this problem. We are really responsible for the opiate epidemic, ultimately. And I guess that's the other reason why you should, at least out of guilt, get training in addiction. If you feel guilty, don't go to Al-Anon or Codependent Anonymous. Get training in addiction. So why treat opiate? I want you to treat opiate addiction. And that's going to be my message today here at the end is what I'm trying to warm up to is that I want you all to treat it. I want you to get training in it. I want you to be able to treat some of the opiate addiction you're going to see. Because we don't have enough people to treat it, and we have treatments that work, but not enough people to implement. We're not, even if everybody in this room started prescribing treatments and started seeing people for opiate addiction, it still wouldn't be enough. And I know that a lot of folks don't want to treat addicts. They think they have their own ideas about it, and maybe, I don't blame you. I don't particularly want to treat, other problems. I mean, I want to treat psychiatric problems, but, I didn't particularly want to be, I didn't want to treat hepatitis and treat liver disease, but I ended up doing that a lot. So it's epidemic proportions. You will not escape it, and it's now actually really treatable. There's a lot of medical complications from opioid use, not just IV drug use either. How many people have seen liver failure from all the acetaminophen that people have ingested because of opiates? Yeah, that's another common problem. So one of the answers I noticed was one of the manufacturers is now making hydrocodone without any acetaminophen. That's their solution to that problem. Thank you. That's going to help. That solves it right there. It's not a bad idea, but still. So anyway, I want to stop for questions here in a little bit. So, telling people to stop and get clean from opiate addiction and get into 12-step work is not a bad thing to do. And I know a lot of people, and I have friends and colleagues and staff that I work with who have done just that. They've gotten clean and sober, and they've abstained from opiates. They didn't get on methadone maintenance. And in fact, many of them are anti-methadone. And Suboxone came along. How many people are familiar with Suboxone already and have heard? Anybody got their data waiver right now who prescribe it? So not very many people. So we'll talk a little bit about that. Suboxone is not very popular among a lot of people in the recovery movement or the abstinence movement, although quite a few are moving towards it. And part of the reason is opiate dependence is a very lethal addiction, and it doesn't have a very good prognosis. Sustained remission is very difficult to achieve. Study that my friend pointed out to me, who left recently, Dr. Billy Barclay, I didn't mention, but very influential person, pointed out that he'd come across this study that was done in California that followed heroin addicts over 30 years, which is pretty impressive. And what they found out was only 23% were not using opiates after 33 years, and over half of them were dead. And that's, I think, what we're seeing. Particularly when you see it's not just the overdoses, but all the trauma and the other things that end up killing a lot of these. And there's even something worse going on too with these young people who they don't seem to have the good judgment they're not as careful as maybe the epidemic in the 70s, the heroin addicts were then. They seem to overdose more, and they're using IV heroin and they're snorting it, and we've made the prescription opiates less available, and that's good, but now we're really running into a heroin problem. So it's very hard to treat heroin addiction and opiate addiction. It's very hard to treat it. It's very resistant. We detox them at JDAC with clonidine and Neurontin. We don't use narcotics. And we help about maybe 1 out of 5 or maybe a third, maybe maintain some recovery, which is still impressive, but you could argue that's placebo. But a lot of people come up to me still and say, boy, I really got help there, thank you. But there's an awful lot of people who continue to relapse and continue to suffer. So there's a treatment that's controversial. It probably shouldn't be as controversial as it is, but it actually addresses this problem. And it came on, and it's buprenorphine or Suboxone. And I use it in my office at the ACOC. And I can only see 100 patients. I can't see any more than that. And it's very effective for a number of patients who get addicted to opiates. And I'm going to run out of time. So what I just want to say is it's not just for psychiatrists. It really is not meant just for psychiatrists to prescribe. It's meant for primary care doctors, internists, anyone. The OBs here are starting to use it, have been using it, and the pregnant women who get addicted. We have an epidemic of pregnant women that's been very, very challenging to our system. And people who use Suboxone generally are pretty pleased with it, meaning the physicians are pretty pleased with it. And most of the people who are prescribing it aren't addiction specialists and aren't psychiatrists. And although House Bill 1 has scared everybody to death about prescribing narcotics and having to check a CASPR, you should have been checking CASPRs anyway with this epidemic. And they're not on a witch hunt to go after people. They really aren't. The board is too busy. They're swamped right now. They don't have time to go after, they want to go after people who are basically running pill mills and essentially engaging in malpractice that they've not been able to go after. And they're so busy with that, they're really not interested in coming after someone who's trying to do a good job and afraid to prescribe pain medication because of all the requirements on it now. It's probably as effective as methadone without a lot of the side effects, and it's available through an office setting. And there's pharmacological properties of Suboxone that make it actually have less abuse potential. And so you can get free training online, 8 hours. It's free, and if you're a resident, and probably at a minimal cost if you're an attending or private practitioner. And you can get what's called a data waiver, which is in addition to your DEA. And I'll list the SAMHSA on here. You can get on the SAMHSA website if you're interested, or talk to me about it. But you can apply for a waiver, and that's really all that requires for you to be able to prescribe this drug for addiction in your office. These patients will be grateful. They'll show up. Not all of them will miraculously get clean, but I've seen enough people who were really untreatable by any other standard. They were not treatable, who have gotten better. Yes, I have a lot of patients who have not done as well on this, and for them, I tell them, if they're screwing around with it or smoking pot or taking other drugs with it, I always say, you're really messing up one of the best chances that you have to get clean right now. It's not made me a popular guy with some of my colleagues that I've been doing this, but it's too important to not talk about. So it's also another way for you to get involved in addiction medicine. Burns gets mad and says, buprenorphine, Suboxone is not addiction medicine, and he's absolutely right. It's not. There's a lot more to addiction medicine than this. But it's a way that you can get inside the door, and you're dealing with this epidemic in this hospital at this time to such a large degree that I want you to, hopefully you'll consider it. Let me talk about this case that I had, and then I'll stop for questions. I had a patient who I saw on consult. I used to do consults for about 2 or 3 years at Norton's, and I still miss some of that. I enjoy doing consult liaison work an awful lot. I like working with other disciplines and other departments. And I saw this patient last year up on, I don't know what floor it was, med-surg, and he had just overdosed, and he was still saying he wanted to die. And when someone overdoses and they say they still want to die, we generally keep those patients. We generally admit them. That's brilliant psychiatric evaluative skills. But when someone says, I wished I had succeeded, we keep those patients. And his wife was there, and he was depressed. And he said, she's an alcoholic, and that's what he told me. And she said, yeah, I think I am too. Again, brilliant deductive evaluation on my part. We were talking, and she's depressed, and he's wanting to die. And as it turns out, he's a heroin addict, but he's been addicted to opiates for a while now, and he's got severe carpal tunnel because he's a talented carpenter and a very talented he showed me pictures of his work. He was a real artist. He was an artist, and he was very unpleasant. In fact, my real instinct was to run screaming from him and not try to help him at all. I mean, he was just an absolutely nasty, nasty state. He was very unpleasant. I didn't want to be in the room with the guy. But for some reason I didn't. I decided that I would try. I thought it was against my better judgment, but I would try some Suboxone. I talked to him about buprenorphine. And at the time, we've been told by a lot of experts in addiction and pain management that buprenorphine is not very effective for pain. And that turns out not to be entirely true. It's probably helpful, and more helpful than we thought. And so if you're prescribing people pain medication and they get addicted to pain, that's another reason why you should be able to prescribe Suboxone, because you may end up having to get someone off of pain medication. But anyway, the story is I treated him for a year, and he is now off Suboxone, and is being treated for depression and is doing really, really well. And I saw him recently, and he is not taking, he's not on anything for pain besides occasional Tylenol, and really has seemingly learned how to deal with his life in a new way. And he's not a guy who would have done well. He would probably be dead. And I really think it saved his life. So, I could go on and on and on. I really hope I covered enough salient points that you'll remember this presentation. At least you'll remember the part about how I met my wife. Thanks for listening. If you want to contact me and you have questions, there's my email. And please consider KaiSam if you're not a member. And there's a lot of support in that organization for learning how to treat addiction, and as well as certification and training. So thanks for your time.
Thank you. I have 2 questions for you.
Yes, sir.
Thank you. I have a couple of questions for you. The first one is, you mentioned that the dopamine pathway, and that almost all of these drugs really have a similar or an endpoint pathway that relates to dopamine.
That's right.
In smoking cessation, there's a new drug that is a partial agonist for certain receptors because it affects dopamine and so forth. That's right. So what is this new drug related to that pathway? What are we doing about tackling that pathway since it's so common for most of these conditions?
Sure. Well, is this on? Okay, good. Well, as it turns out, we've tried, the dopamine agonists are the stimulants. And although it's controversial, stimulants are being used and being researched to treat addiction. Antidepressants that work on the dopamine pathways, but we've really not found any medication at this point that essentially supports or activates or maintains that pathway to the point where someone stops using the drug. But as far as what kind of active research is going on, a whole lot is going on, particularly around, you mentioned varenicline. There's a drug called Vyvanse. People heard of that one. It's being used with cocaine quite a bit, because cocaine is very involved in, more so in dopamine directly, and stimulants are directly. Vyvanse is being looked at with regard to stimulant addiction. The other thing is, can we target the areas of the brain that deal with this? This is my research, without medication, but in some other way. Obviously, if I talk to you, I'm going through your frontal lobe. That's part of the problem. Your frontal lobe's been damaged by your use. So one of the ideas...
My wife tells me that all the time.
Mine too. And by way of speaking, one way is, can we stimulate that part of the brain? Some people are looking at deep brain stimulation. People heard of TMS. We're looking at TMS for depression, because dopamine is also implicated in depression as well. And some certain structures, but they're so deep in the brain that they're hard to get to through the skin surface. So we don't have a magic bullet ultimately. But is it helping our understanding? Absolutely. And I don't know, the different drugs do enough things differently too that just the final common pathway alone doesn't seem to be enough. So yeah, but that's a great question.
The other point I wanted to make is not a question, it's a comment, but you may want to comment on this. In Arizona, we don't like for people to do profiling. In the airports, we do profiling.
Yes.
I would urge the legislature to do some profiling. These blanket statements about how to address addiction by creating problematic, difficult ways of addressing the simplest patients is problematic. I would like for them to do some profiling. If we have a good sense of who are the people who are more likely to be addicted, why can't we tackle them in our legislative efforts, as opposed to in sometimes irrational approach to everything that prevents my 75-year-old man from getting codeine for a cough that prevents him from sleeping.
Right.
What do you think about that?
Well, for every complex problem, there's usually a simple answer, and it's usually wrong. And there is not an easy answer for that, right? I mean, we're talking this is a very highly complex social, political, biological problem, and it's been around a long, long time. And I think that my sympathy with the people who have done some of the legislation recently is with they're trying to do something. They waited far too long doing nothing, and we literally had no one saw this epidemic coming of all the deaths that we've had. Did anybody know it was? I didn't know it was coming, and I knew it was going to be bad, but I did not know it was going to be this bad. And it has corrupted systems in healthcare and all across. I mean, down to it's corrupted our criminal justice system. It's corrupted our medical system. It has been extremely destructive to our infrastructure, our communities. Places are completely wiped out because of this addiction. And so I'm sympathetic that they try to do something, and I agree with you, yes, it's unfortunate. Pain being the fifth vital sign is part of what got us into this, without really an appreciation for that these drugs can be addicting. We were told that they're not addicting, you can prescribe it. We were lied to by the drug, but we took it on and believed it, and we prescribed a lot of these opiates and created this epidemic that started in Appalachia and spread to the entire country. And but it is right, you're right. People are going to suffer now. There's people who can't get pain medication who legitimately need it, will benefit from it, will be safe, and that is the dilemma, right? It's a great dilemma. It's not going away. You're right. And profiling, I'll say a little bit about that. There's a risk evaluation and integration strategy is a new buzzword you're going to hear about with the prescription of opiates, and we probably are going to be at a point where you can do a genetic test in a few years, where you can take someone's blood work, do a test, and based on the genetics, you can say whether they're at increased risk of getting addicted to the opiates or not. Now that's scary in some ways. Yeah.
Matt, hey, GI, so I'm really glad that you brought up a little bit. I wish you could have gone into a little more detail about the heroin problem.
Okay.
There's a new epidemic that the national news has picked up on. I haven't heard it discussed in Louisville. I want to make sure everyone in the room is aware of this. But there's an epidemic of acute hepatitis C in 20-year-olds here in Kentucky.
Right.
We're seeing it in clinics for hepatitis C or transplant center. This is 50, 60-year-old individuals that used in the 70s and 80s. We don't have kids. We don't have kids on hepatitis C treatment because they didn't get their oxys due to tests for whatever reason. It's easier to get heroin. Huge problems. Whether you get any insight on that.
Well, buprenorphine makes a lot of sense in that patient because they get first engaged in treatment, and I've got a lot of patients in hepatitis treatment who started on buprenorphine. They got to stop the heroin first, right? They're not going to, if you're waiting around for them to get clean, if they can't stay clean, which they're not going to, then methadone or buprenorphine. That's what they're going to have to do. And there's downsides to that. And maybe they can't afford the buprenorphine. Right now it's expensive. Suboxone's not cheap. But they could maybe get on methadone, right?
Is it more expensive than their street drugs that they're buying?
Sometimes. Yeah, heroin has been pretty cheap. It just depends, and they may have somebody providing the drugs for them. Again, it's probably about $500 to $600 maybe out of pocket a month to do Suboxone when you count everything else. Maybe less than that, maybe $300 to $400. It's probably still less than that in heroin to some degree. A lot of patients do spend more than that per month. Where do they get this money, right? It's like the problem too is when you start doing Suboxone, you stop doing some of those other things, and so then you don't have the money. So that's another problem. We don't have the resources, and we have this huge population, and it's going to cost us more on the other end because the hepatitis C epidemic, for example, and we can name HIV, tuberculosis, a number of other problems. And so yeah, it's going to cost us one way or the other. And so yeah, I think that's why we need more training, more people training like yourself. If you're going to treat hepatitis, well, you're going to have to learn how to treat addiction. So see me after.
You have a question over there?
Yes.
How long do you have to give them the Suboxone, and do you ever see people getting dependent? I had a pregnant patient who, she really seemed dependent on her Suboxone. Because it was so expensive, we were having trouble getting it for her.
Well, if you take
Can you
some.
repeat a short version of that
Sure.
question?
So do people get dependent on Suboxone? Dependency versus addiction, we could talk about one, which is if you're dependent on something, it just means you go into withdrawal when you quit taking it, essentially. Addiction means you're out of control with the use, you use more and more, you're preoccupied with using it, you spend all your spare time trying to get that drug, and it really disrupts your life. Being dependent on something is you taking it the way it's prescribed. If you take Suboxone, you will be dependent on it, because if you quit taking it, you're going to get sick, and you're going to be dope sick. And anybody who ever has been dope sick does not want to be dope sick ever again. They even develop panic disorder anticipating being dope sick. So yes, it's a crisis in that person's life that they have to be immediately taken off. If there's someone who's actually pregnant, was this a pregnant patient? So I could do a separate talk about that. I treat a lot of pregnant women. Methadone was probably the thing that she needs to consider, depending on where she's at in the pregnancy. But you can't just take a pregnant woman off opiates because they're going to withdrawal, and we think there's an increased risk of labor. So I won't detox a pregnant woman in the first trimester, although probably could do that. But there's a whole lot of information about how do you manage a pregnant woman who's addicted, and you probably, there's Project Link at JDAC. They will get involved and provide case management and help that particular patient you're talking about with resources. And they may not be able to get them on Suboxone, but they might be able to help with methadone, or help at least have her have the safe medical detox while she's pregnant. And I'd be the one to do that.
Last question, Lori.
Thank you.
Thank you so much for your talk, and I think you did a good job of just looking at a global issue that we're facing, our issues. I was wondering if you could comment on the implementation of House Bill 1 and how it seems very heavy on interrupting access to these substances, but I don't see a lot being done legislatively for research and treatment of addiction, which seems to be a huge problem that you highlighted today. And do you think that part of that difficulty in treatment is that there's such a divided addiction community between the people who say, total abstinence, and then those who say harm reduction? Do you think that's impeding progress?
Well, we're at a point now where we're going, in order to get to the next place, we're going to have to move away from dogmatic treatment and the belief that there's one way to do it. And there have to be, patients need options, and they need to have choices. That's in any treatment, and that's the truth. And so we're moving towards that. We have more options for patients. Addiction is still a chronic problem in a lot of cases. There's definitely a move. My fellow let me know the other day that I've been saying for a long time, it's a chronic disease. And for a lot of patients it is. There are patients where it's still not a chronic problem. They have a period of time in their life where they'll have trouble, and then it goes into remission. And that's important for reimbursement, because patients get labeled with addiction. It follows them the rest of their lives, and they can't get insurance. To your point about research and treatment and the emphasis on enforcement, and the emphasis on monitoring, and the emphasis on the criminal justice system and corrections, it's killing us, right? It's not working, and there's a big lawsuit down at the jail right now because of deaths. We were talking about that. I don't think the cavalry's coming there either, though. I don't see any light at the end of the tunnel for research and treatment, other than maybe these large organizations that will support research and treatment because it's in their interest to do so, because it will reduce their cost on that end. But that's been a very difficult thing to demonstrate convincingly. But as we get better at treatment, that's hopefully going to happen. I think we're in addiction treatment to where we were with maybe cancer in the 60s and 70s. We're going to have a point where we really have many more things worked out in the future. So this is what we need to do for this particular problem, and this is the algorithm you need to follow, and this is what the evidence shows. But in Kentucky, it's a dark time. So thank you
very much. Thank you, everybody. Thank you. Appreciate it. All right. Stay on board if you don't mind having
Sure.